racism is alive and well in the United States, and there's institutional racism, and academic medical centers are not exempt from it, and we suffer from it as well as anyone. From an NIH perspective, the Congress in 1993 has required the NIH to include women and minorities in all NIH-funded, taxpayer-supported research. So we asked the question, how have we done as a nation in the last 22 years? In the last 22 years, we just published that less than 4.5% of all NIH taxpayer-supported research has funded populations that include non-European populations. And that's a problem because in the United States, for common diseases like asthma, which is the most commonly chronic disease of children, the highest prevalence and death rates are amongst minorities, and yet they're not included in basic clinical biomedical research. To address this, when I came to UCSF, my colleagues and I created the largest data set of minority children in the US with asthma. One of the strongest results that we've published was that the strongest predictor of drug response was racial and ethnic background. The populations with the highest prevalence, the highest death rates from asthma also had the lowest drug response, and they tended to be minority populations. So what we've done with genetics and advanced technologies, we've been able to identify people that are good responders to medications and people that are poor responders. And now the next step is to take it further and say, what's the best medication for you as an individual patient versus what's the best one-size-fits-all medication? And that's a significant advancement for precision medicine. And that's what we do at UCSF.